Assalamu alaikum. Let's dive into postpartum pregnancy. In this topic, in this part of the obstetric, I would like to discuss about the problems regarding postpartum. Start with the late and postpartum pregnancy. Okay. Uh, Definition of late term or post term gestation. Late term is more than 41 weeks. Late term is more or equal 41 weeks of gestation, and post term is more or 42 weeks of gestation. Post term is 42 more than 42 weeks of gestation, and late term is 41 or more than 41 weeks of gestation. What are the risk factors for post term pregnancy? Prior post term, nulliparity, obesity, age more than 35 or more, and fetal anomalies. If there is anencephaly, absent calvarium, there is absent calvarium, nulliparity, obesity, age more than 35, prior postpartum. These are the risk factors for late or postpartum pregnancy. What are the complications can happen? So there are some fetal or non-neonatal complications. There are some maternal complications. In fetal complication, there may be fetal macrosomia, dysmaturity syndrome, there may be oligohydramnias, and there may be fetal demise. And for maternal, there may be severe obstetric laceration, cesarean delivery, and PPH, postpartum hemorrhage. Management is frequent fetal monitoring like NST non-stress test and delivery prior to 43 weeks of gestation. We need to deliver prior to 43 weeks of gestation. These are all about post term and late term pregnancy. If you find signs of uteroplacental insufficiency or fetal demise, go for immediate delivery. Immediate delivery. Placental sulfate um, placental sulfate deficiency is a risk factor for post-term delivery. Other risk factors include fetal adrenal hyperplasia and anencephaly. So placental sulfatase deficiency, fetal adrenal hyperplasia, and anencephaly. These are the risk factor for post-term delivery. Now third trimester bleeding. Start with this placenta previa. In placenta previa, painless, causeless, recurrent. So placenta previa, prior cesarean delivery or other uterine surgery, there may be multiparity and advanced maternal age. These are the cause of placenta previa. So prior placenta previa, adverse maternal age, prior placenta previa, advanced maternal age, prior cesarean section or uterine surgery, and multiparity. Clinical feature is painless third trimester bleeding. Painless, there may be painless third trimester bleeding. This is a very high L point. This is a painless. Diagnosis transabdominal followed by transvaginal sonography and no intercourse or digital vaginal examination should be done. So, a stable patient with mild bleed, IV fluid, and observation. Unstable patient, active bleeding, emergency cesarean section should be done. Patient who present with vaginal bleeding after 20 weeks of gestation should not go digital cervical examination until ultrasound has been performed to determine the exact location of the placenta. Risk of causing massive hemorrhage if it is placenta previa. If it is placenta previa, you do digital cervical examination. There is a chance of massive bleeding. What recommendation you make for diagnosis of placenta previa? Pelvic rest, abstinence from intercourse, pelvic rest, abstinence from intercourse, and treatment is scheduled CS at 36 to 38 7 weeks of gestation. So pelvic rest, abstinence from intercourse, and as a treatment should do CS at 36 to 37 weeks of gestation. The majority, 90% of the case, resolves spontaneously due to lower uterine segment lengthening and placental growth toward the fundus. And initial management with routine obstetric care. And initial management is routine obstetric care. Okay, look at this question. 20 weeks of gestation, followed up of a prenatal ultrasound. The patient has no pelvic pain, fluid or vaginal bleeding. Look at this line. Ultrasound shows a single fetus in breech presentation and a placenta covering the internal cervical os. When placenta covers the internal cervical os and cervical length is 4.2 centimeter, looks like placenta previa. And as there is no bleeding, patient is hemodynamically stable, just routine obstetric care. So placenta previa, one of the risk factor is prior placenta previa, prior cesarean delivery, and maternal multiple gestation. Painless vaginal bleeding more than 20 weeks of gestation, transabdominal ultrasound followed by the transvaginal sonography. No intercourse, no digital cervical examination, inpatient admission for bleeding episodes. So the majority of the cases resolve spontaneously due to lower uterine segment lengthening and placental growth towards the fundus, and therefore initial management is just routine obstetric care. Pelvic rest and abstinence from abstinence from intercourse due to potential cervical contact are recommended, and clinicians should refrain from digital cervical examination, and repeat ultrasound is performed at third trimester. More than 28 weeks of gestation, patients with placenta previa resolution can continue routine care without pelvic rest restriction. Asymptomatic patient, no vaginal bleeding, placenta previa can undergo scheduled cesarean section at 36 to 37 weeks of gestation. Okay, so when placenta covering the internal cervical os looks like placenta previa. Okay, now read this stem. This 34-year-old woman. So she came with the complaint when that she is on 24 weeks of gestation. There is vaginal bleeding after intercourse. There is bleeding after intercourse. The patient has two cesarean delivery at term and a cervical conization earlier this year. The cervical conization this year. Fetal monitoring 140 per minute. There is acceleration, absent deceleration. There is acceleration, absent deceleration, and moderate variability. The most important part in the here on a speckle examination, there are a large clot in the vaginal wall and a closed cervix and an active bleeding from the os. So this patient there is painless bleeding. It starts after sexual intercourse. Looks like it is placenta previa. So this patient vaginal bleeding after 20 weeks due to placenta previa in which The placenta covers the cervix. Placenta covers the cervix. Risk factor may be prior cesarean. She has a prior to cesarean delivery and multiparity, and there is additional risk factor include prior placenta previa and multiple gestation. So her bleeding starts after sexual intercourse, and she had a history of prior placenta previa. So that's why it is placenta previa. And a treatment depends on the maternal hemodynamic stability and the fetal status. Stable patients are managed expectantly as placenta previa resolves by the third trimester, and patients with persistent previa undergo cesarean section at 36 to 37 weeks of gestation. Now look at these stem. In this stem, what we have found, look at this line, a posterior placenta that covers the cervix. She's 20 weeks of gestation, and we know that the placenta previa, painless vaginal bleeding after 20 weeks. So 20 weeks of gestation, and most importantly, on ultrasound, there is a posterior placenta that extends over the cervix. And what would be its risk factor? What would be its greatest risk factor for the ultrasound finding? So looks like placenta previa, and its risk factors are prior placenta previa, prior cesarean section, and multiple gestation. She is only gravitated to para 1. So prior cesarean delivery is the answer. This is the placenta. This is the cervical canal. This is internal cervical os. So this is external cervical os, cervical canal, internal os, external os. So this is the placenta. So looks like this patient has placenta previa, in which the placenta extends over and covers the cervix. Extends over and covers the cervix. Most patients asymptomatic are incidentally diagnosed on the second trimester, as in these patients, and placenta patients with placenta previa require pelvic rest because minimal cervical manipulation can cause cervical changes, shortening, dilatation that can result in partial detachment and massive maternal hemorrhage. Okay, so look at this question. Uh, Vasa previa. Vasa previa, fetal vessel overlying the cervix. Fetal vessels overlying the cervix. One of the risk factors is again placenta previa, multiple gestation, placenta previa, multiple gestation, in vitro IVF, in vitro fertilization, and succinsurate placental lobe. In here again, painless vaginal bleeding. In placenta previa, there is painless vaginal bleeding with a rupture of the membrane or contraction, fetal heart rate abnormal, bradycardia, sinusoidal pattern. This is the sinusoidal pattern. And fetal exsanguination and demise, emergency CS. So CS, Vasa CS. In here it looks like painless vaginal bleeding. It is just like placenta previa. So one of the risk factor is again placenta previa and multiple gestation. Uh, in Vasa previa, no prior CS is the risk factor. In here, another risk factor added like IVF. Okay, uterine rupture. What is the most important risk factor for uterine rupture? Previous cesarean section or myomectomy. Previous cesarean section or myomectomy is the most important risk factor for uterine rupture. Scar becomes the weakest point of the uterus. Presentation Painful third trimester bleeding, sudden abdominal pain during labor, loss of fetal station, palpable fetal pulse on abdominal examination, and fetal heart rate deceleration, bradycardia. So, painless third trimester bleeding, sudden abdominal pain during labor, loss of fetal station, palpable fetal pulse on the abdominal examination, and fetal heart rate deceleration, bradycardia. Laboring patients at high risk of uterine rupture and require urgent laparotomy and delivery. This is uterine rupture. This is uterine rupture. This is the uterine contraction look like staircase sign. Placental abruption or abruption placenta, placental detachment from the uterus before fetal delivery. Before delivery, if there is placental detachment not covering the cervix, when placenta covers the cervix, it is placenta previa, but abruption placenta, there is placental detachment. It may be due to hypertension, preeclampsia, abdominal trauma, prior abruption placenta, abdominal trauma, prior abruption placenta, cocaine and tobacco, sudden abdominal vaginal bleeding, abdominal back pain, a rigid tender uterus, high frequency and low intensity contraction, rigid and tender uterus. It is clinical and ultrasound and retroplacental hematoma. Ultrasound show with or without retroplacental hematoma. Complication is fetal hypoxia, preterm birth, mortality, maternal hemorrhage, DIC, maternal hemorrhage, DIC should be done. Painful bleeding which may be concealed, regular high frequency contraction versus irregular and decreasing in uterine rupture over 20 weeks of gestation. Uterine tachysystole, more than 5 contraction in 10 minutes. Okay, now what is the most what is the most initial what is the most initial management in a hemodynamically unstable patient and an unstable pregnant patient presents with abruption placenta following a water vehicle oxygen IV fluid resuscitation and left lateral decubitus position. Left lateral decubitus position displaces the uterus of the aortocaval vessel and maximizes left lateral displaces the uterus of the aortocaval vessel and maximizes cardiac output. So, hemodynamic unstable pregnant woman that presents with abruption placenta, what should you do? IV fluid follow and left lateral decubitus positioning. Okay, if we look at this question, 35 weeks of gestation, more than that means more than 20 weeks of pregnancy, leakage of fluid, painless vaginal bleeding. So what are my differential? My differential is either placenta previa or maybe vasa previa. The patient has a rupture of the membrane 30 minutes ago. She has rupture membrane. The fluid was initially clear but now becomes bloody, this and that. And she has two pregnancy resulting in term cesarean sections. So uh, prior cesarean she has in term cesarean delivery she has hypertension, but stopped her medication when she became pregnant. This is a very grave mistake she has done. So she has hypertension, stopped taking medication. She stopped taking medication. And on one another thing we have to remember that uh, term cesarean delivery is not a risk factor for one cases. Can you tell me the name? In Vasa previa, prior cesarean section is risk factor, but of cesarean section. That means cesarean section is the risk factor for placenta previa, but not for Vasa previa. You need to remember that. But she has done a very bad job. Like she has hypertension, but she stopped taking medication. This is a very bad thing she has done. Speculum examination, there is rupture membrane, cervical os is 1 centimeter dilated, minimum vaginal bleeding, Doppler show um, unable to detect fetal heart tone. So looks like this is Vasa previa. That means fetal vessel overlying the cervix. It may be due to multiple gestation, it may be due to placenta previa, it may be due to IVF. So normal fetal vessel travel the umbilical cord and surrounding the thick gelatinous tissue. In contrast, vasa previa is an aberrant condition in which fetal vessel overlie the cervix. Fetal vessel overlie the cervix and surrounded by a thin rim of fetal membrane. The location of the cervix and the lack of protection of the Wharton jelly makes these vessels prone to tear with rupture membrane. So this patient has painless vaginal, minimal vaginal fetal blood loss. Okay, vaginal bleeding is minimal because total fetal blood volume is low, 250 ml or 1 cup. However, hypotension from the fetal bleeding leads to fetal heart rate abnormality. Hypotension from the fetal bleeding leads to fetal heart rate abnormality, bradycardia, sinusoidal pattern, and rapid fetal exsanguination and demise. So Vasa, this patient has Vasa previa, that means fetal vessel overlie the cervix and making them prone to rupture, and there is painless. And how we have diagnosed that it is Vasa previa? Doppler shows there is no fetal heart tones. There is no fetal heart tone. So fetal vessel actually overlying the cervix and causing this fetal heart rate abnormality. If we look at this question, 33 weeks of gestation antepartum, she is a known case of a Vasa previa. She is a known case of a Vasa previa. She is a known case of Vasa previa. So what should our next thing? We need to do emergency CS. We need to do emergency CS. And if we look at this question, the final question, the last in here there is painful contraction, so looks like painful, and there is bleeding. If there is if there is painful bleeding, constant abdominal pain, fetal heart rate racing 120, so fetal heart rate are kind of normal, uterus smooth, gravity uterus, cervix is 5 centimeter dilated, 100%, effaced with fetal vertex at station. Which is the most likely cause? It is abruptio placentae. So abruptio placentae, heavy vaginal bleeding, abdominal pain, and the rupture of the membrane, this means abruptio placentae. So patients with uterine overdistension, twin gestation, severe polyhydramnios, severe twin gestation, severe polyhydramnios. So she has, this patient has 20-week anatomy ultrasound and a male fetus with tracheoesophageal fistula and a posterior fundal placenta. So she developed increasingly severe polyhydramnios in the most recent amniotic fluid index, measuring 39 centimeters. So problem is due these placenta patients with uterine overdistension, twin and severe polyhydramnios. This is the increased risk of abruptio placentae, and there is rigid tender uterus and uterine irritability. So that's why the diagnosis is abruptio placentae. So this is another thing you need to see, the placenta accreta attached to the myometrium, and this is umbilical cord prolapse, and this is the picture of the Vasa previa, fetal vessel overlying the cervix, fetal vessel overlying within the Wharton jelly, and this is the picture of uterine rupture. Okay, this is all about this lecture. Hope you enjoyed. If you like, share this video.